Okay, MRCS Part A, upper limb anatomy. So we will be very focused specifically for the exam related question. Okay, upper limb. From upper limb, we will get minimum 8 to 10 question, and among them, this brachial plexus is one of the important topic. Brachial plexus is very common. We have seen even in our medical school. Brachial plexus, it forms from cervical 5, 6, 7, 8, and thoracic 1. Yes. And which rami? Ventral rami. Ventral rami of cervical 5, 6, 7, 8, thoracic 1. And all the ventral rami, they join together to form some. These are the roots. These are the root level. Okay. We need to know the different level. From root 5 and 6, they join together to form the upper trunk. Okay. And yes, root trunk, division and cord. C5 and 6 form together to form upper trunk, and lower 2, 8 and T1 form the lower trunk. And C7, Cristiano Ronaldo, he goes through middle. He's alone. He's good enough to go alone. So he remains always in the middle. Then he goes to posterior and posterior, and ultimately he is towards the goal. So cervical 5, 6 forms the upper trunk, and C8, T1 forms the lower trunk, and C7 forms the middle trunk. Every trunk even again divides into anterior, posterior, again anterior, posterior, anterior and posterior. So upper, middle and lower trunk, all three trunks again divide into two divisions. Divisions are anterior and posterior division. Now all the posterior division join together to form the posterior cord. All the posterior division, posterior cord, and the remaining part, like the anterior of both upper and middle trunk, join together to form the lateral cord. Yes. And the lower trunk's anterior cord continues as like the medial cord. Anterior division continues as like the medial cord. Okay. Then we finish root, trunk, division, cord. Then we have the branches. From the cord, we have different branches. Okay. We have seen the posterior cord is forming by union of all the posterior division of the trunks. Yeah. And we need. Yeah. Okay. Okay. Now, see, from the root level, we have few nerves. Okay. This is the maximum size in my screen. Maybe in your setting, you can just try to have some view, any view of shown, anything, because MacBook setting maybe it's a little different.
It's okay.
You can zoom in, zoom out.
Yeah,
Okay.
I know that, but it's
Yeah.
just that automatic.
Okay. So from the root we have dorsal scapular nerve. Very important. This is exam question. Dorsal scapular nerve root cervical 5, C5, and it originates from the root level. Dorsal scapular nerve. Okay. Also, we have another nerve, long thoracic nerve of Bell, or long thoracic nerve. Root value cervical 5, 6, 7. C5, 6, 7. Long thoracic nerve. C5, C6, C7, all they form together to make long thoracic nerve, and it gives supplies to serratus anterior muscle. Okay,
Yeah.
so in the root
Many of
level,
scapula if it gets
mhm,
damaged.
yes, yes. From the root level, we have dorsal. In the trunk level, we have in the trunk level we have subscapular nerve. Okay,
Okay.
subscapular nerve
Yeah.
C5-6
Subscapular.
and subclavius C5.
Subclavius. Okay.
Yeah, lateral pectoral nerve C5-6-7. Lateral pectoral nerve
In the cord.
in the cord level. Lateral pectoral nerve
Fascia.
and mhm. So
Medial.
one is lateral, another one is medial pectoral nerve.
Medial
Okay,
pectoral.
okay,
Fascia.
yeah.
Fascia.
And from the posterior cord, just remember this mnemonic, ulnar, ULNAR, ULNAR. From the posterior ulnar, how we will remember? U for upper and L for lower, subscapular nerve, upper and lower subscapular nerve. Then this,
Subscapular nerve.
mhm, this N for
Nerve to
nerve
latissimus
to latissimus
axillary
dorsi,
and radius.
A for axillary, and R for radius. These all are the posterior branches. Okay,
Posterior branches from cord.
posterior cord. Yeah,
Posterior cord
branches from the
branches.
posterior cord. Branches from the posterior cord. Ulnar.
Towards the scapular nerve to the latissimus nerve and to the scapular.
Mm-hmm. Ulnar. This is a mnemonic, not the real ulnar nerve. This is we have
Yeah,
to
yeah,
remember very carefully because ulnar nerve it comes from the medial cord. Okay, but we are saying posterior cord nerve we can remember by this mnemonic ulnar. Upper and lower subscapular nerve, nerve to latissimus dorsi, axillary nerve, and radial nerve. All are posterior, posterior, posterior finish. Now, lateral. Lateral dividing into two. See, lateral, one lateral going laterally, one lateral coming medially. Okay, so the branch which is going lateral and going laterally, it is musculocutaneous nerve, one of the very important for the upper limb. Musculocutaneous nerve. Musculocutaneous nerve, root vellus cervical 5-7. Okay, and the medial branch coming medially, also the medial cord again dividing into one branch going medially, another branch going medial. Okay, they both are joining together to form a nerve which is median nerve. Median nerve. So median nerve having two roots, one coming from the lateral cord, another coming from the
lateral and
medial cord.
medial cord.
Medial
Okay,
cord.
these are fibers actually.
Yeah, these are the fibers. These are the fibers, as like the sciatic nerve. Okay, half portion coming from the lateral, half portion from the medial. So median nerve, root vellus cervical 5 to thoracic 1. Now,
C6.
yeah, we already got this axillary nerve, radial nerve, axillary radial. These are the branches from where?
These are the branches from the lateral.
Posterior. These are the branches from the posterior. Axillary. ULNA for axillary and R for
Oh yeah,
posterior.
axillary.
Mhm. Yeah, yeah.
Median has little fibers, the lateral and the medial, and
Yes.
the medial has and the musculocutaneous.
Yeah.
That's really fibers.
And some other branches like medial cutaneous nerve of medial root of the median nerve. This is medial root of the median
Okay.
nerve. Okay. Exactly.
Okay.
A mark should be here. Okay. So here you can see C5 root, dorsal scapular nerve. Okay, C5-6-7 root, long thoracic nerve of bell gives supply. to serratus anterior muscle in the upper trunk, subscapular nerve. It gives supply infraspinatus and supraspinatus. Okay, we will get this. Just I tried to accumulate all the information in one page. Lateral cord, we have lateral root of the median nerve, lateral pectoral nerve, and
Yeah.
musculocutaneous nerve. These
Lateral
are
root
from
of
the
median nerve.
lateral cord, and from medial cord we have medial root of
Medial
median nerve,
cutaneous nerve, medial pectoral nerve, and
medial pectoral,
fibrous nerve.
median nerve. Okay. Now posterior cord, it is ulnar. Already we have seen upper and lower subscapular nerve, nerve to let us
Yeah.
make dorsal, axillary nerve, and radial.
Axillary nerve and radial.
Okay. Now, if there is any nerve injury, especially from C5 and C6, there will be an injury called Erb's palsy, or it has a presentation like a waiter's teeth, and it is called waiter tips deformity. Exam, they asked about the root value. A person fell down and overstressed his hand, and he is unable to do this and that movement. Which deformity? Erb's
Adducted arm,
palsy. Mm-hmm.
outstretched arm,
Yes,
adducted.
yes.
C5, C6. Yeah.
Root value.
Waiter's deformity.
Mainly, we have to remember root value, C5, C6. And if it is lower, then it is called Klumpf's palsy. Okay,
CH1. Yeah.
C8
Klumpix. Yeah.
Klumpf's
Yeah.
palsy.
Is it like
Mm-hmm.
like claw?
Yeah, we will get flowing of the fingers. We will get. Now see the cutaneous distribution of the upper limb. Okay,
Yeah.
cutaneous distribution. Just imagine our neck region. It is C3. Badge area or shoulder badge area, it is C4. Then anterior lateral aspect of the arm, C5 up to the elbow and the upper part of the forearm. This is C5, important one. Then lower up to the lateral half of the index finger, up to the lateral C6. Again, C7 is very powerful. He takes middle, he likes to be in the middle, C7. Again, as like uh, uh, brachial plexus. C7 in the middle, and he collects half from both sides, half of the index, half of the ring. Okay, so this is C7, C7. And the little finger is C8 up to the middle of the forearm, C8.
C8. Yeah.
Then
Mm-hmm.
elbow region up to the half of the forearm arm is T1. Then upper arm medial aspect T2, axilla T3, and nipple line T4. Again, cervical region C3, shoulder or badge area C4, down up to the upper part of the forearm C5, then from the lower
C5.
part of the
C6.
forearm, arm,
To the first index finger.
half of the index C6, mid finger, half of the index, half of the ring
C7.
C7, little finger
C8.
C8, elbow T1, upper arm T2, axilla
Axilla.
T3, and T4. Now we have seen musculocutaneous nerve here. Remember, from the lateral
Yeah.
cord we were getting C5, C7 musculocutaneous nerve, and it gives supply to BBC. Musculocutaneous gives supply to BBC. Brachialis, biceps brachii,
Brachialis, biceps brachii, coracobrachialis.
coracobrachialis. brachialis,
Biceps,
coracobrachialis,
right?
biceps brachii.
Yeah.
If there is C5 and C6 injury, mainly musculocutaneous nerve and axillary nerve, they will be affected. Okay. From here, you need to remember if axillary nerve gives supply to two big muscles. One is deltoid,
Deltoid
another one
and the source minor.
teres minor.
Teres minor.
Teres,
Oh,
teres minor. Yes, one
source
big,
minor
one
and
small.
deltoid.
Yes, yes, it is common. So axillary nerve, it gives supply one big muscle, one small muscle. Big is deltoid and small is minor. Minor, small, small teres. Okay. Deltoid causes abductor of the shoulder. Abduction of the shoulder. It takes away the shoulder away from the body or
Away
elevates
from the
the
body.
shoulder. Mhm. And teres minor, it causes lateral rotation of the shoulder. Now, if this is injured, what will happen? Abduction of the shoulder will be impaired. So shoulder will be adducted as like here, and lateral rotation of the shoulder will be impaired. So shoulder will be medially rotated. Shoulder will be medially rotated. So
Medially rotated.
also the deltoid gives supply over this area, this badge area, this area, regimental badge or the army they put their badges this area. So there will be loss of sensation down the lateral side of the forearm here also. Okay.
Yes, yes, that's right. So axillary and muscular rotation will be increased in case of this C5 C6 pulse, C5 C6 pulse.
Yes.
Axillary muscular rotated. So lateral side of the arm will not be like sensations will be lost, lateral aspect of the arm, lateral action, and axillary supplies two major muscles, teres minor and deltoid. Deltoid causes the abduction and teres minor causes lateral rotation of the shoulder. So these two functions will be impaired. So the shoulder will be adducted and medially rotated.
Hmm. Hmm. Now, uh, as we said, C5 and C6 injury, it will cause impairment of the suprascapular nerve, and suprascapular nerve gives supply to these muscles, supraspinatus and infraspinatus. Supraspinatus and infraspinatus supplied by the suprascapular nerve, and subclavius is by nerve to subclavius. Okay. And what will happen? Supraspinatus causes abduction of the shoulder, and infraspinatus causes lateral rotation of the shoulder, as like
Okay.
teres minor. So teres minor and infraspinatus together they cause the lateral rotation of the shoulder. If it is impaired, then all their function will be impaired. So opposite in our body, what actually happens? Any muscle, what they cause their normal action. If it is impaired, then opposite action will happen. For example, deltoid causes abduction. If it is impaired, shoulder will be in the opposite direction because uh, to maintain every joint in their stable position, there is joint stability maintained by the ligament and the tendon, and they pull in opposite direction. So if if adduction function is impaired, opposite side they will not sit ideally. They will continue their function as like Bell's palsy. Remember Bell's palsy? If one side
Yeah.
of the face muscle is paralyzed, so the healthy side they pull towards their side. So it looks like a impairment. The same when if palsy is there, the opposite direction of the muscle X. As a result, it looks like this type of pattern. It is so shoulder will be adducted, medially rotated,
Medially rotated.
and forearm will be pronated and towards facing backward. So it looks like someone taking money from the backside, and it is given the name of waiter's deformity. Okay, so upper limb will hang by the side, medially rotated by the unopposed sternocostal part of the pectoralis major. The forearm will be pronated because of the loss of the action of the biceps, and porter or waiter hinting for the tip. These all are MRCS Part D question. If you prepare here for Part B, you no need to stress. Okay. Now, Klumpig's palsy. In Klumpig's palsy, there will be uh, C8 and T1 injury. It usually happens over stress. If shoulder joint is overstressed, like hanging, someone hanging, and the whole body weight is transmitted through the shoulder joint. Due to the overstress, the lower part, the lower, here, the lower part of the, that is C8 and T1 will be impaired. And patient will come with hand flowing loss of wrist flexion. It is something like this. Okay, sometimes it happens due to breech delivery. If a hand breech delivery, then it can happen. So, loss of sensation along the medial side of the forearm, hand, and medial to finger. If they give this type of scenario, so it is Klumpig's palsy.
Klumpy's palsy.
Yeah.
Obviously, ulnar.
Yes, ulnar. Now brachial plexus. As we spent a lot of time on the picture, this is just the description of the picture. Okay. Long thoracic nerve, their root value, and which muscle they supply, subscapular nerve, and their supplied muscles, supraspinatus, infraspinatus, and glenohumeral joint or the shoulder joint. Okay, musculocutaneous nerve, very important. Musculocutaneous nerve, BBC, and root value C567, C567, 567. If I read 100 times, I forget 100 times. This one, musculocutaneous nerve, C5, 6, and 7. And they give supply B, B, C. B for brachialis, biceps brachii, coracobrachialis. And very important, this is also another question. Musculocutaneous nerve continues as lateral cutaneous nerve of forearm. Very important. This is a question. I think it came in my exam. Musculocutaneous nerve, when they yes. Now ulnar nerve. It comes from which cord? Okay. Ulnar nerve and radial nerve. Ulnar and radial. They fight always. Okay. Ulnar nerve and radial nerve, they always fight to capture. Ulnar nerve and median. Ulnar nerve and median nerve. Radial nerve is radial. I remember radial R for royal. And royal is like the king of the back. So ulnar nerve innervates half of the flexor muscle in the forearm. Median nerve we speak? No. Median nerve. If you remember only one topic from upper limb, that is median nerve. You forget everything, but remember everything about median nerve. Okay. So median nerve, lateral root of the median nerve is the terminal branch of the lateral cord. Remember the picture. Lateral root of the median nerve, it has a lateral root and it has a medial root, and they join together to form the
Yes,
median nerve.
to
So
form the median nerve.
yes, so lateral root of the median nerve is the terminal branch of the lateral cord,
Lateral
and
cord. Yes.
and the medial root of the median nerve is the terminal branch of the medial cord. So they are ultimately here it is written C8T1, but actually in median nerve we will get their C from C6. Remember the picture? Median nerve
Yeah.
C6 to T1. Okay, C6 to T1. Median nerve from C6 to T1. Okay. So median nerve, we got how it is formed. It is formed by the lateral root and the medial root. Lateral root and medial roots combining to form the median nerve. Now they are supplied. Very important. Median nerve remains in the anterior aspect. Very simple. Median nerve gives supply in the anterior aspect of the forearm. And which part? Flexor muscles in the forearm. Flexor muscles in the forearm, except flexor carpi ulnaris, because its name is ulnaris. So of course it will
Supplied
be
by the
supplied by
ulnar.
the ulnar.
Yes,
And
and the other
the
half.
ulnar half flexor digitorum profundus, both ulnar related. These both muscle are anterior compartment of the forearm muscle, or the flexor
Yes, that's
compartment.
right. That's right.
Remember,
Yes.
in the lower limb, anterior compartment was flexor or extensor.
Extensive.
Okay, and posterior compartment was
They were flexors.
flexor. Yeah, just opposite in the upper limb.
Yeah.
Upper limb anterior compartment is flexor, posterior compartment is extensor. So
Extensor.
common rules: all the flexors of the forearm is supplied by the median nerve, except flexor carpi ulnaris,
Except the flexor
flexor
carpi
ulnaris, and
and ulnar half of the flexor digitorum profundus.
ulnar half of the flexor digitorum profundus. This flexor digitorum profundus, FDP, is my one of the favorite muscle. Okay, it has two half. Yeah, this is very nice. Flexor digitorum profundus, because it is supplied by one half is supplied by median nerve, one half is supplied by the ulnar nerve. So medial side is supplied by the median nerve. So medial half of the flexor digitorum profundus supplied by the median nerve, and the lateral half of the flexor digitorum profundus is supplied by the ulnar nerve. Okay.
Yeah.
Now the remaining part. 3.5 inner and lateral two lumbrical muscles in the hand. These all are MRCS part B question. 3.5 thinner and lateral two lumbricals. How many lumbricals we have in our hand?
5. 4. 5.
5, 4, 3, 2, 1, go.
5. 5. 5.
5, I think 4.
4.
4.
4. Yes.
Okay.
Yeah.
Okay. So the 3.5 thinner and lateral two lumbricals muscles in the hand and the skin of the palm. Very important, very important. Skin of the palm and 3.5. Always remember, there was a confusion. Sometimes it is called 2.5. No, there is no 2.5 in median nerve. Always it is 3.5. Always it is 3.5. So muscle thinner, 3.5 thinner, also 3.5 digits in the lateral to the line bisecting fold. And is it no need this one. Just remember 3.5 thinner muscle. We will see the picture, it will be more clear. Once again, median nerve supply all the flexors of the forearm except two muscle. Those are
Flexor carpi ulnaris and flexor profundus medial half. No, lateral half. This is supplied by the ulnar nerve, and it also supplies the
no.
metatarsal nerve.
You said lateral half. Better to
Which
say better to say
ulnar
ulnar half. Ulnar half.
ulnar half?
Ulnar half. Alna, you know Alna in our country, in Bangladesh, Alna is a kind of furniture in our home where we used to keep the clothes. And Alna always remain inside the room. So it is in the inner part, medial part. Okay. So medial side is ulnar side, and lateral side is radial side. The radial is like the road, and road always remain outside of the home. And Alna is the furniture, it remains inside the home. Okay. So 3.5 thinner, 3.5 thinner. Which thinner? This is the lateral side. Median nerve gives supply to the lateral side and the lateral two lumbrical muscle in the hand and skin also. Palmar aspect of the hand, 3.5 digits lateral to the 9, dissecting fourth digit and the dorsum of the distal halves of these digits. Okay, no need. Now see here 3.5. So how much remaining? Because in our hand we have total 5, right? 5 if we divide in these two half, one is 3.5, another will be 1.5.
One and a half.
1.5, there is no 2.5. Remember this thing. Median and ulnar nerve always distribution is 3.5, 1.5. So 3.5 median nerve is very aggressive, it takes more. Median nerve always take 3.5 and the remaining 1.5 it is taken by the ulnar nerve. So now ulnar nerve, you see, innervates 1.5 flexor muscle in the forearm. Which part? Flexor carpi ulnaris.
Yes,
Okay.
flexor carpi ulnaris.
And the ulnar half of the flexor digitorum profundus. So FDP also have one half supplied by the median nerve, another half supplied by the ulnar nerve. That's why here they are mentioning 1.5 flexor muscle in the forearm and here thinner part 3.5 taken by median. So 1.5 will be by the
One and a
ulnar
half would be the ulnar. Yeah.
and they said lateral two lumbrical by median. So medial two lumbricals by ulnar and all interossei muscle. This is a $1 million question. All interossei muscle in the hand is supplied by the ulnar nerve. All interossei muscle are supplied by the ulnar nerve. And the
By
skin
the
of the
ulnar.
skin of the hand medial to the 9 distal no need. Okay. Now axillary nerve. Axillary nerve we already seen they give supply one big, one small. Small
Deltoid,
is
minor, and deltoid.
yes, there is minor and deltoid. And the radial, I feel radial is very gentle and very humble person, and he is a male. Radial, very humble. It always, yes, it remains always in the back, but he is like a king, like a royal person. Okay, and see what he does. He gives supply to the big muscle and very important function it provides. So radial, it is coming from where?
C5
U
or V1.
L N A R. Remember this, Minami? Ulnar. These are for
Posterior trunk.
posterior cord. Posterior cord.
Posterior cord.
Hmm. So ulnar nerve is coming from the posterior cord, and it is remaining in the posterior. It is coming from the posterior cord, remaining in the posterior, and he don't like any fighting. He is very peace-minded. We will see the ulnar nerve distribution, then we will remember this thing. So they give supply all the posterior aspect of the forearm and the arm, even the hand. So this is very unique. They give supply to the triceps brachii. Biceps brachii was supplied by who? Who?
Musculocutaneous.
Yes. And in short, we say it biceps muscle, right? The gym guy, they used to build their biceps and triceps. So simple, biceps is supplied by musculocutaneous nerve, and triceps is supplied by
Radial.
radial nerve. So triceps brachii, anconeus, brachioradialis, and the extensor muscle of the forearm. Flexor, flexors of the forearm is supplied by
Musculocutaneous.
no, flexor of the forearm.
Oh, flexor. I'll tell you. Medial nerve.
Okay, except
Except extensor nervi are that, and upper shaft is buttress.
yes, supplies the skin on posterior aspect of the arm and the forearm and the dorsum of the hand and lateral to the axial line of the digit 4. So mostly radial nerve, it is originating from the posterior, giving supply to the posterior, and it is going up to the posterior.
Okay.
Now nerve injury. Nerve injury. Okay. Long thoracic nerve. Remember, long thoracic nerve of bell. It was root bell was C5, C6, and C7.
C6, C7, C5, C6, C7 from the
And
root, uh,
yes,
venue of scapula. Yeah.
okay. Long thoracic nerve. Doctor, I got some food.
Wow.
So I'm listening to you. You can read.
So long thoracic nerve is usually injured in the stab wound and mastectomy, and causes the impairment through the abduction of the shoulder and the transverse scapula is compromised. Test pushing against the wall causes broken scapula. So this is a long thoracic nerve. Then we have the axillary nerve. Axillary nerve is the surgical neck fracture of the humerus and the anterior dislocation of the shoulder. So neck of the femur fracture, neck of the humerus fracture, yeah, and anterior femur shoulder
Neck of the
dislocation.
femur or
No, neck
humerus.
of the I said humerus,
Remember
abduction.
this type of scenario in the exam. If they say during mastectomy, so click it in head. It could be long thoracic nerve injury. During surgical neck of humerus fracture, blindly you can answer axillary nerve. Okay, like hip surgery, posterior dislocation of the hip. Which nerve will be injured?
Sciatic.
Sciatic nerve. Like this. You need to find out the keywords in the question because here, see, you are solving EMRCS or today you have given exam. These are very short version of the question. In real exam, question will be the whole page of the screen. Very long scenario, irrelevant, many things. They will say about the vitals. Patient presented with this, BP was this, temperature was this. These all are not necessary. Just it is killing your time. So if you know which part will direct you towards the answer, that will make it easy. Okay, continue. Axillary nerve.
So yeah, fracture of the fracture of the neck of the surgical neck of the humerus, and then the abduction of the shoulder joint to the horizontal is compromised because it supplies the deltoid joint digit. So abduct the shoulder the median nerve, it depends on the fracture, on the like lesion, it's proximal or distal. If it is like supraapicondyle proximal lesion, then the median nerve is damaged. So this could be the forehand or the hand abduction, where the flexor of the wrist can had when the VA to the ulnar side during flexion of the wrist, flexion of the distal interphalangeal proximal to brachial and um, metacarpophalangeal joints of the index and the middle finger. Lost abduction of the flexion of the thumb joints are lost. Sensory loss on the palm and in the dorsal aspect of the index and middle finger. So yeah, so absence of the thumb opposition, because yeah, absence of the thumb opposition and hand abduction. And if the wrist is joint, sorry, if it is damaged at the wrist, median nerve, then it is the carpal tunnel disease. Claw hand, no, not the claw hand, carpal tunnel. Yes, it may close due to trauma and injury. Carpal tunnel and hand open addiction of forehand. Ulnar nerve, if it damages at the elbow, medial epicondyle juncture, then it will be claw hand. The hand will delegate to the inside flexion of these arteries, claw hand. And the ulnar nerve at the wrist, if it is damaged, so slashing of the wrist. Okay. I thought it's the complete claw or the partial claw. Ulnar paradox. More higher the more higher the lesion and elbow less lesion. Ulnar abrasion. The flexor injured renal rickets. So flexion at the interphalangeal joint is neglected. Okay, yes. Because it supplies the ulnar half of the flexor into the fundus. So as we go up, so that will be compromised, and vice versa, more clawing. Because as we move more distally, then the half of the MTP is met with the median nerve. So that proximal medial half of the process of flexion of the interphalangeal nerves. Yeah. So the ulnar paradox is higher the lesion, lesser the risk. Yeah, partial clawing proximal and more clawing distal or at the wrist.
Okay, so
So
from
what's
here,
next, doctor?
still I'm thinking it is soup, my favorite.
Just the soup.
And yeah, it was very tasty.
Yeah, but
Before,
why more like
no, I'm continuing. Okay, here from this chart, you will get minimum 2 or 3 questions just only from this chart, and this is the clue. Nobody will tell you. But if you remember this chart properly, be 100% sure you will get minimum 2 or 3 questions. Anatomy is like the math. You cannot lose a single mark. You will pass with the anatomy mark. In part A, it is a benefit that you no need to pass individually. I mean, overall, if your score is up to the mark, you are pass. But for part B, you have to pass individually, both clinical part and knowledge part. So once again, you already studied long thoracic nerve. there will be winning of the scapula. Main part, winning of the scapula. Then axillary nerve, there will be uh, anesthesia over the
Deltoid
cervic
or
deltoid.
abduction of the shoulder, which is there.
Yes, radial nerve injury. There will be radial
Wrist
nerve
drop.
wrist drop, radial nerve wrist drop, radial nerve wrist drop, because radial nerve gives supply in the extensor aspect of the hand, right? Yes, in the posterior, radial is royal for king, goes posterior. So posterior aspect means for the extension, it has to raise this part, right? As it is lost, so
Yeah.
it will fall down, wrist drop, because extension of the wrist and the joints is lost. Median nerve injury, it can happen. Median nerve, it is very long, and median nerve, we have already seen, it has two roots, medial root and lateral root, medial root and lateral root. So median nerve, if it is injured at the elbow joint, how it can be injured? Why? Supraepicondylar fracture, supraepicondylar fracture of the humerus. Then in the elbow joint, what will happen?
Hope hand or hand
Thumb
fracture.
opposition. Thumb opposition will be impaired. So it will look like hand of benediction, like this picture. In the question, they will write like opposition of the thumb is impaired. Patient presented to accident and emergency with this fracture and found patient cannot oppose his thumb. Which nerve injured? Or median nerve injured at which level? Elbow level.
Proximal. Elbow.
Elbow. And now at the wrist level, median nerve, wrist level, mainly it will show the feature of carpal tunnel syndrome. And carpal tunnel syndrome, in part B, we will see how we examine all the nerve and median nerve. There is one trick to make a OK sign or O sign with the thumb and index. And if it is injured, patient cannot make this O, because these FDP is very nice tendon. Flexor digitorum profundus. They
Profundus.
in our finger, these are the, suppose this is the joint, phalanx. This is the phalanx. This is another phalanx. How many phalanx we have in suppose index finger?
Three.
Three. So FDP actually joined in the base of the distal phalanx. Okay, base of the distal phalanx here. To make
Yeah,
it
but
flex, to make a OK sign,
yeah.
our distal phalanx has to bend forward or has to have the flexion. If it is injured, then patient cannot bend his the distal phalanx. Okay, so ultimately patient will not be able to make the OK sign, and the DIP yeah, will remain as like straight. We'll get all this explanation in DIP and PIP. DIP is distal interphalangeal joint,
Interphalangeal phalanx
and
and NIP
PIP,
metatarsophalangeal.
yes, yeah, and PIP, proximal interphalangeal. This is PIP, proximal interphalangeal.
Yeah. Uh-huh.
So median nerve injury in two level. If it is injured in the elbow level, we will have hand of benediction. If it is injured in the wrist level, we will have carpal tunnel.
Carpal tunnel.
Now ulnar nerve, ulnar nerve, ulnar paradox. Remember ulnar paradox. This is the exam question. Ulnar paradox. More higher the lesion means if ulnar nerve injured at above the elbow joint. More higher the lesion, less clawing.
Less flowing.
Clawing uh, means flexion of the fingers, right?
Yeah. Yeah.
So we have seen flexor of the forearm and the arm, even the hand, mainly delivered by which nerve? Median nerve.
Median nerve.
Median nerve. And uh, median nerve takes most of the part, like three and half portion, right? So mainly flexion function is maintaining by the median nerve, but one third also not that much less. This one third is maintained by the ulnar nerve flexion.
ulnar nerve.
But if it is injured, if ulnar nerve injured in the upper, suppose this is elbow, this is hand, and this is arm. If ulnar nerve injured at this level, already to cause the flexion, median nerve is there. So median nerve serving its purpose. Okay,
So
but
like there will be some flexion, partial.
yes, yes, partial. And if it is injured in the wrist joint, so there will be more flowing. Just remember in a simple way, more upper the lesion, less flowing, lower the lesion, uh,
More flowing.
yes. Now we will see a gross idea about their orientation. See, this is lateral cord, posterior cord, and the medial cord. Posterior cord is dedicated for C7, represents Cristiano Ronaldo, which remains always in the middle, and remains in the middle. But lateral, see, this is lateral coming laterally, and then it is coming anterior. This is overall a gross idea about the orientation. And the posterior, this is the posterior. See, posterior, it is going posteriorly, and at the elbow joint, it is coming in front of the bone. Then again, it is feeling shy, so going again back posterior. Radial nerve always in the posterior, only in the elbow joint. The lateral epicondyle, it comes in front, and then again it goes back. Okay, so this is radial nerve, and radial nerve always remain in the posterior, in the arm, forearm, and the hand. Now come to the medial side. Medial side, I said ulna is a name of furniture. It remains inside the room, so it is medial side. That's why
Yes.
ulnar nerve always in the medial aspect of the body, upper arm, and ulna is like very shy. She don't come in front. She goes posteriorly and going back and continue medially, and give the medial half. And we said in the hand always two muscle fighting. Which muscle? Nerve, ulnar,
Ulnar and median.
and median. So median is very aggressive. Median is taking one, two, three, and the half of the index. These three is taken by the median nerve, and this just one and half finger is by ulnar. And radial nerve will not fight with none of them. The radial nerve will not come in anterior aspect. He will remain in the back, as like here you can see radial nerve in the posterior aspect, cutaneous supply also here. But these median nerve and ulnar nerve, they fight very badly, that they cover the flexor aspect and they go to the extensor aspect also, means both dorsum and ventral surface. So in the posterior aspect, ulnar nerve remains the same, one and half finger, anterior and posterior, both side, anterior and posterior. See here also ulnar nerve covering the same, anterior and posterior, one and half. But median nerve is so aggressive, it captured the anterior, also it is capturing the posterior aspect of thumb, index, and mid finger. But which part? Which part? Which part? Only the tip, 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 tip of the fingers.
Tip, tip of the fingers.
Because this posterior aspect is mainly for the radial nerve, because radial is
Radial nerve.
sole nerve. So, arm, forearm, and in the hand, mainly it is supplied by the radial nerve, except the tip of the thumb, index, and mid finger. Even the ring finger is very typical. Ring finger, its tip half is supplied by the median nerve, another half is supplied by the ulnar nerve. Okay, this is axillary nerve. Okay, axillary nerve, median nerve. We have seen ulnar nerve, and here is the cutaneous supply. Already we have seen in which part which nerve is supplying, right? This picture is very important, very important, very important. See, ulnar nerve, it is supplying anterior aspect, 1.5 finger,
And the posterior aspect, same 1.5 finger.
one
While
and
the
a half
median
finger.
is supplying 3.5 anterior aspect, and the posterior gets the tips of the three fingers and half of the ring finger.
Hmm. And remaining by
Remaining is radial.
radial. Okay, now deltoid. Okay, deltoid, it has three parts. Deltoid has three parts. Anterior, this is deltoid. See, it has anterior part. Anteriorly, it is attached with the clavicle, or it is called clavicular part. Posteriorly, it is attached with the spine of the scapula. This is scapula, spine of the scapula. Posterior part is attached with the spine of the scapula. And middle part is attached with the acromion process of the scapula. So we can say acromial part, spinal part, and clavicular part. Or we can say anterior part or clavicular part, posterior part or the spinal part, and the medial part or middle part or the acromion part. Okay, and these are their origin, and they are inserting into deltoid tuberosity. Now trapezius, it has three groups of muscle. Some muscle, they are coming down from above, so these are the descending fibers of the trapezius. Some are going up, so ascending fiber, and some are horizontal,
Transverse fibers,
like the transverse fibers.
descending and transverse.
Yeah. Okay. Okay. So see the direction of serratus, posterior and inferior, then latissimus dorsi and teres major. Just get some orientation about their location. Now trapezius, latissimus dorsi, levator superior, deltoid. Deltoid is important. We have already seen it is supplied by the axillary nerve, good value 5, 6, and insert into the deltoid tuberosity. These all are MRCS part B question. No need. Remember the function of the deltoid. Okay. Anterior part. Anterior part causes flexion and medial rotation of the shoulder. So anterior part causes flexion and medial rotation. Posterior part will cause just the opposite, extension
Extension and
and
lateral
lateral
rotation.
rotation. And main function of the deltoid is the medial, anterior posterior and medial. Middle part causes the shoulder abduction, ABD.
So I have to take a call. Is that all right? I have to take
Yeah, sure. You will allow me to have some food.
Oh, yeah, thank you.
Yeah. Yeah, yes, sure.
Oh, I'm so sorry for the wait. Just
No, no, no,
sorry.
no problem. No problem. No problem.
Rota, rot, yeah, it's just the rota silence and all
This is
that.
very common. Very common.
Yeah, yeah,
What
too difficult.
what we can do? I have seen the remaining part. What we can do? We can conclude it here tonight, and
Yes, please.
we can finish.
Yes. Can you
Most
send me this as well so that I'll just read it on my phone as well?
Yeah,
Send me
sure.
whatever you were
Yeah, yeah.
asking. Yeah.
hmm I will send most of the part we have actually seen. Okay, so the remaining part will not be that much difficult.
Hmm. It's
Tomorrow,
just that if I have studied
mhm,
my own, if I have studied my own part, then I can see the things
mhm. No problem. I will forward this file, and tomorrow we can finish this one. Then we will go through the EMR. Tomorrow, same. I have morning duty. If you can manage time, then maybe in the morning time we can finish this remaining lecture.
Yes, I think I should be able to do it. I have theater tomorrow. It depends on what are the theater and how many people are there. But we can do definitely.
In EMRCS, you have to put more effort because in this lecture file, apart from this lecture file, many other things you need to read in details from this EMRCS. You can see the
Like the explanations, you mean?
yeah explanation, mostly the highlighted part. I have to read. Anyway, tomorrow let us finish lecture first, then we will go for this.
I
So,
don't mind
so
taking a couple of days as well.
yeah, same. I'm also saying, but uh, my purpose is to you need to have the orientation of what is your syllabus, what you need to study, and how deep you need to study. Once you know the syllabus, you will know. Suppose now you prepared lower limb, and next time when you have time, I mean, you have any exam for upper limb and lower limb, you know where which part will take more time. So this is your first round, and I will try to update the rota. Then I will send you. But we can conclude tonight after here.
Okay.
Okay, doctor. Thank you, and
All right.
once again,
Thank you so
well
much.
done. You have done very well
Yeah.
in the exam. Otherwise, I would have stopped with you.
I know you are very strict student, but you can get anyone past MRCS.
Yeah, I have to.
Yeah.
You can do it. You can do it.